Our next speaker is Professor Anne Ralph. Professor Ralph is an infectious disease consultant working up in Darwin, Royal Darwin Hospital. And she has a research interest in tropical infectious diseases as well as many other things. And she's going to be talking to us about pulmonary infections in tropical Australia. So I'll hand over to you.
And thanks very much for inviting me to talk. And I really enjoyed listening to the previous speaker. So I'll start with acknowledgements because I have to say that this pneumonia isn't really my research area, so I'm really delivering this talk from my perspective as a clinician. I've listed many people to thank: infectious diseases physicians at Royal Darwin Hospital, and also Ella Moyman, who's helped me with understanding some of the antibiotics aspects, and at the end there, Jen O'Hearn and Chris Lowbridge, whose research I'll be talking about very briefly in this presentation. So why do we think differently in the tropics? So when it applies to pneumonia, this is really because I'm sure, as many people will know, the etiology does differ in the top end of Australia compared to other parts of Australia, given our endemic tropical pneumonia pathogens. And this therefore influences our local guidelines, obviously. But in addition to that, there's differing host susceptibility, with high rates of some of the risk factors that lead to high rates of severe pneumonias, and also our geography, whereby a lot of people live very remote from health centres, certainly from tertiary care. All of these things contribute to often quite severe presentations. Now, I'm going to see if this works. I'm hopeful that it might. So if you have a device, can you please scan the QR code so that you can participate in some multiple choice questions? I'll just give you a moment to get out your phone and do that if you can. So I'm just going to share some X-ray pictures and ask you some questions. So we'll see how we go. So here are a couple of X-rays showing an infection with the same organism. So the clinical story for the first X-ray is that this is a 45-year-old Aboriginal male presenting to Royal Darwin Hospital with cough, fever and malaise for a week. What organism do you think this is? So the options I was going to give you for these, what these organisms might be, obviously this is a bit of a trick question. When you look at this, you think tuberculosis. It's upper lobe infiltrates. In the first X-ray, you can see cavity formation there with a fairly thick wall. And the presenting symptoms do sound like they could fit with TB, maybe slightly more acute than what you'd expect for that. But in fact, both of these X-rays are from people with melioidosis, so Burkholderia pseudomallei, and these really just highlight the fact that that endemic pathogen, gram-negative organism that we have in the top end soils and waters can really mimic other conditions, including tuberculosis. And same for this presentation, this can mimic other things as well. This is a 35-year-old female presenting with cough, fever and headache for several weeks. And the question list for this for these images was what test would you do first? And often what happens when people are unfamiliar with this is that they proceed to doing a lung biopsy fairly soon in the piece, whereas a cryptococcal antigen obviously is what's going to sort of help you get to an answer, because usually in our context that's going to be Cryptococcus gattii. So let's just move on then, if I can. Yep, there we go. So what I'm going to do then, just after giving you a bit of a taster of some of the organisms that we see commonly, is just talk about our clinical practice guidelines. We divide them on several ways, so depending on the severity and on the presence of risk factors, and whether it's wet or dry season, and whether we suspect MRSA or not. So all of those sort of things are taken into account in coming up with the empirical regimen prior to knowing what the organism is. In terms of what are we talking about when we talk about risk factors, so we're really referring to diabetes, hazardous alcohol use, chronic lung disease, chronic kidney disease of stage 3 or more, and steroids or other immunosuppression. And that's because these are really what have been identified as being the key risk factors for Burkholderia pseudomallei, serious pneumonias. And they also happen to be the risk factors for Acinetobacter baumannii, which we also see as a community-acquired pneumonia. So then looking at what are the top organisms that cause pneumonia in the tropics. This, as you can see, is a really old slide for looking at data from 30 to 40 years ago. This was published by Julian Elliott in 2005. But the thing is that it sort of really does remain much the same. So our top cause, as for everywhere else, is strep pneumo. But the second most common is the Burkholderia pseudomallei, followed by Staph aureus, and then the Acinetobacter baumannii community-acquired infection. We have looked at this again slightly more recently. This was a much smaller study, but again, just demonstrating that again, those organisms are some of the top ones still, maybe slightly less Acinetobacter in this series. And this, sorry, it's such a messy slide, but the point of this is just to demonstrate that of our staffs, about 63% are MSSA, 36% are MRSA, and nearly all of those MRSAs are non-multis. Just something else to point out in this slide is that we do have pretty good penicillin susceptibility amongst the strep pneumos. So going back to this, the guideline that we use then, so for mild pneumonia and moderate pneumonia without risk factors, the recommended treatment is largely the same as elsewhere in Australia. What you do see missing from this obviously is atypical cover. So even with the much wider use now of multiplex PCR on respiratory samples, which really gives us a better picture of what the burden of Mycoplasma, Chlamydia and Legionella infections are in the Northern Territory, we really don't see very much atypical infection. And so for that reason in our guideline, it's sort of considered optional. It's up to the physician caring for the patient whether they feel it's appropriate to add in doxycycline or not, until you get to the severes, in which case azithromycin is included in the regimen. So just to explain why some of these antibiotics are chosen. So what you can see is the introduction of ceftriaxone gent as the antibiotic protocol for moderate pneumonia with risk factors or severe non-ICU pneumonia. And it's sort of an interesting rationale for that. It's partly because ceftriaxone at that high dose of 2 grams does give some efficacy against Burkholderia pseudomallei whilst you're awaiting culture results. And the gentamicin is there for both the Acinetobacter and also is considered to be an appropriate agent to be using for MRSA. Because, as I said, our MRSAs tend to be the non-multis which are susceptible to gent. And especially considering that these antibiotics often need to be given out of hospital in the remote setting or on flight during retrieval into hospital, trying to provide a regimen that's accessible and feasible in the remote setting also weighs into the decision making here. Having said that, we now do have sepsis packs available for remote retrievals. So in consultation with infectious diseases, meropenem and or vancomycin can be used prior to hospital, which is really important given that those presentations to hospital are often so late. So what you can see in the severe ICU pneumonias, the regimen at this time of year is azithromycin meropenem because we're in the wet season, whereas sort of between about April and October, it's pip/taz and azithromycin, and then plus or minus vanc, depending on whether it looks like, whether you're concerned about MRSA being the pathogen. So that's really it on our our protocol. What I'm just going to talk about in the next, I think I've got 10 minutes remaining, not sure, is NT research into tropical endemic pathogens. So there is a lot that I could potentially cover here. But I don't have time for. So just to mention, I suppose that the CDC, the Public Health Unit in the Northern Territory, has really sort of been at the forefront of early introduction of vaccines for strep pneumo in particular. And there's been a lot of research from Anne Chang's Child Health Unit into vaccine efficacy in the local population. Also, a lot of excellent research into bronchiectasis, of which we have very high rates. But I won't be talking about that. I'm going to focus a bit more on melioidosis for starters. So Professor Bart Curry is the one that's been leading this research for the last 3 decades and has put together this data as a 30-year prospective observational investigation published in Lancet ID a couple of years ago. And this prospective study is ongoing. This paper brought together data from over 1,000 people with melioidosis and was able to look at some really interesting trends over that period of time and tell us some further facts about melioidosis. So the case rate is about 21 cases per 100,000 people overall in the top end. But that case rate is 104 per 100,000 among Indigenous or First Nations peoples. For those that are less familiar with this organism, so this is associated with tropical soils in Australia, generally above about the Tropic of Capricorn, and affecting Western Australia, Queensland and Northern Territory, with occasional cases more south of that, depending on weather. So 80% of infections occur during the wet season and are definitely associated with flooding events and cyclones, for instance. And that plot on the side there shows the relationship between the case numbers and tropical cyclones. The other thing that it obviously shows is that there has been an increase in case numbers over time, and that rising incidence of melioidosis over 30 years isn't just due to case detection. It does represent a true increase. And one of the important reasons for that is environmental disturbance. So there's been a lot of development in the suburbs around Darwin with the creation of new suburbs around Palmerston and so forth. And that environmental disruption with earthworks going on and disrupting the soil is thought to be associated with more cases. And in addition, we do have a population with escalating risk factors over time. So type 2 diabetes, for instance, is a huge and escalating problem in the Northern Australian population. We do have more people on, getting access to cancer therapies and immunosuppressive therapies for various conditions. So these all contribute to that population being at risk, and those factors together are accounting for this increasing rate of melioidosis. But having said that, a really important outcome from this work has been a major decrease in mortality over the years. So from about 30% of all people presenting with melioidosis in the first 5 years of the study, being the mortality, down to now about 6%. A lot of those gains were made in the early years, recognising the need for broader spectrum antibiotics given the resistance profile of this organism. This is a plot I've taken from Ella Moyman's beautiful paper in Nature Reviews Microbiology this year, which really tells you absolutely everything you need to know about melioidosis. It's a very comprehensive review paper. And this is an interesting map which shows the evidence consensus on whether the organism is demonstrated to be present or absent. And you can definitely see that it's Southeast Asia which is impacted. Obviously, the jurisdictions in Australia that are shaded in red don't have the organism throughout this state, like to the southern parts of those states. But you can see the distribution of the organism there. And I'd certainly encourage people to read this review if you're interested in melioidosis. So how do you treat it? Firstly, the antibiotic treatment we tend to divide into an intensive phase and then an eradication phase. The duration really depends on the type of presentation, whether it's a simple skin presentation without bacteremia and without much severity, in which case you can get away with 2 weeks of an initial intensive phase followed by 3 months eradication, through to deep-seated bone and joint CNS arterial infections, for instance, where you really are needing much longer durations of the intensive phase intravenously. So you can see that this is an infection which really takes up a lot of healthcare resources, and in the wet season, it really adds to the infectious disease burden in the hospital and in the outpatient clinic, and particularly in the hospital in the home setting, where people are getting their home IV antibiotics. So the workhorse antibiotics that we use are ceftazidime or meropenem, and we add in the cotrimoxazole quite early. There's a adjustment currently happening to our protocol, which is to step the cotrimoxazole in gradually rather than starting it at full dose all at once at the beginning, because what we're finding is the very high dose that we use. So it normally, for somebody over around 60 kilos, it comes out at about 2 double-strength tablets twice a day, which is a fairly whopping dose of cotrimoxazole to be using. So the double strength obviously is the 800/160 of trimethoprim sulfamethoxazole. So we do find high levels of intolerability, but there has been work showing that if you step it up gradually, then people do tolerate it better. So that's the approach to treatment for melioidosis. Oh, now I can't move, sorry. Let's try again. I'm going to skip over this slide. I just really like this picture, another one from Ella's paper, but I'll skip over it in the interests of time. To talk about Cryptococcus gattii infections, which I think you can't sort of really avoid when we're talking about pulmonary infections in Northern Australia. So this can present as a differential diagnosis for community-acquired pneumonia, but as I mentioned earlier, more commonly, it gets confused with malignancy because it presents often as a lump, but you can get other forms of Cryptococcus gattii pulmonary infection, so you sort of can have lobar involvement, but classically it's the sort of well demarcated cryptococcoma that we see. So this was a 22-year cohort study that Dr. Jen O'Hearn put together when she was a registrar with us in the Northern Territory. She's now an ID physician in Tasmania. So this was a really comprehensive look at what's happened over time, and reporting on the epidemiology and the clinical features. So this is, interestingly, it's almost solely in First Nations populations. There's probably an element to that of likelihood of exposure to the organism, but there probably is also things that we don't understand about the immunology as to why people are at risk. So generally people are, apparently immunocompetent, which means that they're HIV negative. They don't necessarily have type 2 diabetes. They don't necessarily have end-stage renal failure or the other obvious causes of immunosuppression. But they're obviously not immunocompetent because this infection is occurring. We have started looking at things like anti-interferon gamma autoantibodies and so on. They haven't come up positive in anyone that we've tested for yet that has Cryptococcus gattii infections. We have come across a case in somebody with a disseminated non-tuberculous mycobacterial infection, though, out of interest. So I'm going to talk through this slide just because I think it has some points of interest, especially to an audience interested in antimicrobial stewardship, which really this shows the 22 years of that study and the cases in orange down the bottom, showing how many cases there have been per year. There is this perception that there has been increasing case numbers towards the end. There were more deaths earlier on. There's less deaths these days, as you can see, going along the top there. The sort of surgical interventions people are having, people don't really get access reservoirs for intrathecal amphotericin anymore, but they are more likely to get pulmonary surgery with resection of their cryptococcomas. People are more likely to get treated with azoles other than fluconazole, and you can see that several people more in the later years of this study are receiving voriconazole as their step-down eradication phase treatment on the basis of the fluconazole MIC being 16 or more. and in the past, MIC wasn't always reported. So we don't know that it's necessarily increasing over time, but certainly we've got more reports of those high MICs, and in those cases, we're tending to use voriconazole instead. All right, and so this is these are some intraoperative photos showing that resection of the cryptococcoma, and even after a long period of antifungals, you can still see budding yeasts, which are identified with the red arrow there within that big resected cryptococcoma. So resecting it just means that there's less likelihood of relapse later down the track, and so we do recommend it for larger cryptococcomas of around 3 centimeters or more. So I'm going to have to wrap up in a minute. So just to say that TB is an important issue for us. In the north, this study that Nalanthi Vigneswaran put together was looking at diagnostic delays. As diseases get more rare, clinicians forget to think about them. So we do find that people are often in the community with TB symptoms for weeks or months and not necessarily getting diagnosed. And so in response to that, well, it's two ways. It's delays happening at the patient level and also at the health system level. So in response to that, we have some funding, which my colleague Chris Lowbridge got through MRFF to really do some intensive work at the community level, particularly in the hotspot communities that are experiencing these higher rates of TB, to empower TB-affected communities to shape their response to TB by really upskilling community members and healthcare providers in being able to recognise TB, get people on TB treatment sooner, and also really improve the cascade of care for latent TB treatment or treatment of TB infection. And I think that's actually my last slide. Yeah, I was going to ask one final question. What proportion of locally acquired TB in the NT is drug resistant, multi-drug resistant? And the answer to that, luckily for us at the moment, is 0%. So we just don't have any locally acquired MDR TB. We do have imported MDR TB cases uncommonly, but luckily the locally acquired TB, which is being transmitted at community level, tends to be rifampicin and isoniazid susceptible. So that's where I'm going to leave it. Thank you very much, and I'll hand back. I'll just try to stop sharing. Thank you.
Thank you. That was fantastic. We've got one question which also relates to the question I was going to ask you. So Adam's asked if you could elaborate more on ceftriaxone susceptible amyloidosis. And I guess I was going to ask you as well if your preference is for ceftazidime or meropenem when treating as well, in terms of using efficacy.
Sure. Yeah, thank you. So thanks to Ella Moyman for helping me to answer this question, because I thought this question might come up. That there aren't established clinical breakpoints for ceftriaxone. So but what's quite evident clinically is that at high doses, there is both in vitro and clinical efficacy of ceftriaxone to the extent that we use it in that empirical stage prior to knowing what the organism is. But once melioidosis is identified, we definitely switch away from ceftriaxone to something which is more efficacious, either meropenem or ceftazidime. So it's, I think the MIC values that I've seen reported are around sort of 2 to 4, thereabouts. But as I said, there aren't clinical breakpoints, so it's hard to know how to interpret that. But it is 2 grams of ceftriaxone is sort of like a safe option in that first instance, awaiting cultures. We don't want to be using meropenem for everyone for antimicrobial stewardship purposes, and ceftazidime sort of really isn't adequate against the gram-positive organisms, and so that's why we go with this option initially. In terms of whether we use meropenem or ceftazidime, usually it's ceftazidime, but especially for most severe cases and CNS disease, where you want good CNS penetration, we use meropenem, and we use meropenem at the 2 grams 8-hourly dose for CNS disease. whether meropenem is slightly better than ceftazidime, it probably is, but ceftaz is absolutely adequate in most instances. Sometimes we will swap between them over time. If you've got a rising MIC for someone that's got a big lung abscess and it's taking them months to clear it, sometimes we will see a rising MIC to one antibiotic or the other, and we have to swap and ensure that they're on dual agents with the cotrimoxazole added in as well. And for people that can't tolerate cotrimoxazole, doxycycline is the second line.
Right, yeah, I remember in 2021 when I was the advanced trainee at PA, there was a patient who was very unwell in ICU with amyloidosis, and he developed inducible meropenem resistance on treatment, and we ended up, once we realised that, obviously we changed into ceftazidime. But yeah, it was interesting. I was thinking at the time if we should just use ceftazidime up front. And so just so your practice is to try and get everyone on dual therapy as soon as possible.
Yeah, I mean, obviously for something like a skin infection or a fairly straightforward, simple infection, it's not as critical. But where you're anticipating that there's going to be a long duration of therapy ahead of you, especially for the pulmonary infections where you've got a large organism burden and you're concerned about development of resistance over time, those are particularly the situations where you do want to try to step in that second agent sooner. Sometimes in the ICU setting, when people have got renal failure, they're on dialysis, because often this does present with septic shock and multi-organ failure. You don't want to start the Bactrim too early, because Bactrim has such adverse effects and can confuse when you're trying to monitor liver function and renal function. It really can confuse the picture. But trying to get it in within the first week or so of treatment is what's recommended.